Hello, everyone, and thank you so much for joining us for this edition of CTSNet Roundtable. Today, we'll be discussing healthcare disparities in the treatment of advanced lung cancer. My name is Brittany Williams, and I'm a surgical resident at the University of North Carolina. And I'm fortunate to be joined today by three multidisciplinary leaders in this field. I will now ask each of our panelists to introduce themselves, beginning with Dr. Rivera.
Thank you, Brittany. My name is Patricia Rivera. I'm a professor of medicine in the Division of Pulmonary and Critical Care Medicine and the director of the Lung Cancer Screening Program at UNC.
My name is Marjorie Charlot, and I'm an assistant professor of medicine at UNC School of Medicine. I'm also a thoracic medical oncologist, a health equity researcher, and an assistant director of the Community Outreach and Engagement Office at the UNC Lineberger Comprehensive Cancer Center.
I'm Geetha Modi. I'm the Director of Thoracic Surgical Oncology here at UNC. My clinical interests are in minimally invasive surgery for lung cancer, and research interests are in using health information technology to optimize perioperative outcomes.
Thank you. And so all of our panelists were recently co-authors on a particularly timely review published in the Journal of Thoracic Disease that examined the current state of sociodemographic disparities in the management of advanced lung cancer. Dr. Charlot, could you provide us with some highlights of your findings?
Absolutely. So we evaluated about 22 studies that we included in our review, and we found that there was a consistent pattern of sociodemographic disparities based on race, ethnicity, insurance status, and in some cases, site of care. To name a few of the findings, we found that Black individuals and individuals without insurance were less likely to receive appropriate chemoradiotherapy for stage 3 non-small cell lung cancer. We also found that this similar population, including those with Medicaid, were less likely to receive guideline recommended molecular testing for advanced lung cancer. Other findings included individuals who live in low-income areas were less likely to be prescribed oral targeted therapies and were less likely to receive chemotherapy. We also found that palliative radiation, such as stereotactic radiosurgery for metastatic disease, was less available to minoritized racial and ethnic groups, as well as those of lower income status.
Thank you so much. I think one thing that really stood out to me from that review was the lack of recent literature on this important topic. This is why roundtable discussions like today's are so important for highlighting these gaps and future directions for increasing equity in lung cancer care. Dr. Modi, what do you see as some of the predominant barriers that are influencing lung cancer disparities today?
Sure, thanks, Brittany. You know, as a surgeon, I'm struck that there are disparities in even offering surgery to patients based on their race, their ethnicity, their socioeconomic status, or their rural urban status. And that's very, very important in this current era where we know that their survival outcomes differ amongst these groups. We must make sure that we are offering therapies for the appropriate patients in the ways that are consistent with guidelines. And importantly, in our advanced lung cancer patients, that extends to even something like a staging procedure. We have found that there are gaps in the same profile of socioethnic and other patient makeup that influence something as straightforward as doing proper staging. Now, when we come to procedures or surgeries to palliate patients, we don't even have data that tell us what the differences are amongst these groups. So more research in this area is critically needed.
Yes, definitely. Thank you so much. I think another factor that Dr. Charlot highlighted in the review and recently published an editorial on is the lack of diversity in clinical trials and the limited collection of population level genetic data from particularly minority racial groups. Could you tell us more about the downstream effects that this has had on trial data and clinical care?
Yes, absolutely. So we found, in our review, as well as we were preparing this editorial on precision oncology, that that Black individuals in particular are less likely enrolled onto clinical trials. And we also find this among Latinx populations as well, that they're less likely enrolled in cancer clinical trials. And so one of the sort of downstream effects with molecular testing is that typically molecular markers are part of the criteria, the eligibility criteria for these clinical trials. And so if this testing is not done systematically for minoritized racial and ethnic groups, then these populations are unfortunately excluded from these clinical trials. I would say another downstream effect is that, because these populations are not involved or participating in clinical trials, that they don't necessarily get to benefit from the advances in cancer care as a result of these trials. So a lot of times these trials provide an opportunity for access to cutting edge treatments. And so with the systematic exclusion of minoritized racial and ethnic groups, there's a large pocket of the population that are not getting access to advanced cancer treatment.
Definitely. And I think now that we've discussed some of the barriers that are influencing these disparities in advanced lung cancer care, let's discuss some of the future directions for reducing these inequities. Dr. Rivera, you recently co-authored a statement for the American Thoracic Society on addressing disparities in lung cancer screening. Can you discuss some of the strategies you've seen have the most success?
Thank you, Brittany. Yes, we described disparities in eligibility criteria, which to some extent are being addressed by the revised USPSTF screening recommendations, although we know that despite those revisions, there are still gaps in the number of underserved minority patients who are being screened compared to whites. But it's a step in the right direction. A major problem with disparity to cancer care centers around socioeconomic factors, while race and ethnicity play a major role. There is no doubt that socioeconomic disparities are probably much more impactful, and that has to do with access to care. It has to do with being able to pay for care, particularly for newer innovative modalities such as EBUS, endobronchial ultrasound for staging, and PET scanning, and low-dose CT for lung cancer screening. There are studies that have investigated the role of nurse navigators in the community, helping individuals, particularly individuals at risk for lung cancer who are either suspected or have been found to have lung cancer, or who are eligible for lung cancer screening, to help navigate patients through this very complex process of the healthcare system. And nurse navigators have been shown to be really important and result in improvement, at least when it comes to lung cancer screening, improvement in lung cancer screening rates compared to other screening, breast and colorectal screening. The era of telehealth medicine is now, of course, in the forefront. We had been discussing for years about transitioning to more telehealth visit, but I think COVID-19 taught us that this is a modality that is critically important. And I think that we can potentially reach more patients, at least for the lung cancer screening component, to discuss shared decision-making, tobacco treatment, as well as enrollment and screening itself. But the issue that we have to remember is that access to internet and the digital divide is real, and we have to ensure that if we're going to develop a more robust telehealth approach to reach vulnerable patients in certain communities, that we must be able to provide those services locally, where patients can go to and access, computers and internet, and be able to have their meetings. This is particularly important for tobacco treatment. There are a lot of disparities in terms of referral for tobacco treatment and counseling, even though African American and Hispanics are often more likely to want to quit, they're less likely to be referred, and transportation and getting to a tobacco treatment program can be a hindrance. Telehealth, I think, can make a big impact on getting patients engaged in tobacco treatment. There are investigators that are looking at mobile units, particularly for lung cancer screening. This had been investigated in breast cancer years ago, so that these mobile units can provide the individuals that are readily available to conduct shared decision-making, counseling, and then the low-dose CT can be done in the mobile unit. And then because of the multiple advances in telehealth communication, that review of the low-dose CTs can occur by dedicated radiologists, and then local physicians who are trying to get patients to undergo these very important interventions can have support, if you will, to individuals with a little bit more expertise in this matter and can help navigate findings, particularly on low-dose CT. So there are a lot of interventions in terms of access to care. And then another major barrier is, of course, cost. We know that many individuals that are socioeconomically affected have no insurance or underinsured, and that's a major issue. In the United States, there are many, many states, I believe 9, if not more, that did not expand Medicaid, meaning people who have Medicaid in some states who are at risk for lung cancer don't have access to lung cancer screening because Medicaid won't pay for it. In 1990, the federal government mandated programs to provide breast cancer screening and cervical cancer screening for women who could not pay for it or who were underinsured. And such mandates are, I think, are very important and necessary in lung cancer, which is the most common cause of cancer death for both men and women in the United States.
Yes, thank you so much. And I think on that note of limited access with many of our patients out in the community, Dr. Charlot, can you just tell us some of the current state of the guideline concordant care received by patients in the community and some solutions that we may be able to highlight for reducing these disparities?
Sure. I think as previously mentioned, I think with respect to precision oncology and the emphasis and the focus on, molecular testing and availability of molecular testing, particularly for patients who are receiving their care primarily in community and non-academic settings. And, that tends to be more patients of color, patients who are underinsured, as mentioned by Dr. Rivera, as well as those, typically with Medicaid, tend not to get their care either in private or academic institutions. And so I think part of the solution for ensuring that, all patients have access to guideline recommended care is to have systems in place in terms of clinical pathways as one particular system, but with the understanding that oftentimes these clinical pathways require health information technology infrastructure, which could be very costly. So understanding and addressing these challenges around cost with the use of health information technology, I think is one barrier that needs to be addressed in order to ensure that all patients have access to guideline recommended care. I think another aspect of technology that was already previously mentioned, the use of telehealth with the opportunity to expand, access to, tumor boards virtually in a way where it doesn't necessarily have to be synchronous, but, our community partners could potentially participate in tumor boards, through the use of virtual platforms and using asynchronous platforms, whereby, we work collaboratively with our community partners to ensure that the care that all these patients are getting are consistent with the guidelines. I think that as particularly for lung cancer, as we, move further and further into precision oncology, that, the care is going to be a lot more complex and complicated. And so oftentimes community providers are managing a number of different types of cancer that are also becoming very molecularly driven and advanced and complicated. And so I think decision making, if there are opportunities to make decision making across various cancer types, including lung cancer, with the use of technology, I think that it ensures that patients, regardless of where they're getting their care, that they're getting the highest quality care because it's consistent with guidelines and consistent with the advances that we've seen, particularly for lung cancer.
Thank you so much. I really appreciate this discussion. I will just welcome any additional comments from each of our panelists and end with some final thoughts from Dr. Modi.
I just want to emphasize the importance of these discussions and the importance of bringing this knowledge to all the individuals that are caring for patients. I think we all need to be working together to think about how to minimize disparities across healthcare.
I think one of the final points that I wanted to make before we open up for discussion is that we are this is just a wonderful time, I think, in terms of the state of lung cancer care and the advances that we've seen thus far. And there's certainly a lot more to come. I think that this is a wonderful opportunity to, again, partner with our community providers, because I think that there are ways that we, even as an academic institution, can learn about how to equitably provide care to our patients. I don't think that I think that, again, as a public institution, as previously mentioned, that, there's so much that we can learn. And I think using technology is an opportunity for us to do that across institutions. I think the other thing that I wanted to add as well is that I think with, in terms of patients, minoritized racial and ethnic groups, I think that the onus is on us as providers to ensure that we have systems that allow us to measure our quality of care, because I think oftentimes we let the social determinants of health get in the way of the care that we provide. But I think that we have to recognize as health institutions and health organizations that social determinants of health are very central to the care that we give, and that in order for us to ensure that all patients are able to have, are able to realize improved, survival, improved outcomes in cancer care, that, we won't be able to do this without incorporating social determinants of health into our practice and into the care that we provide.
Couldn't agree more. I really do want to thank you, Dr. Rivera, Dr. Schlo, Dr. Williams, for joining me in this conversation. I think that this is the beginning of a new time in our healthcare. It has to be. And very importantly, we need to recognize and speak about openly the disparities we're seeing in care for our patients. We're here to offer some solutions, but we know that the way forward is going to be research and programmatic initiatives that are going to take these issues head on. And so I, again, thank you all for being part of this conversation, and appreciate our audience for taking the time to listen in today.
Thank you for including me.
Thank you.
Thank you.
An absolute privilege.